Good morning, everybody. Welcome to the Trust Board meeting, the June board meeting, and this is our meeting in public. Thank you very much in advance for those of you joining us virtually and dialing in to join the board meeting. We do appreciate your interest, and a particular mention to our chair designate Caroline Flint, who I know is dialing in, and also to Hanif Malik, our newly appointed Associate Non-Executive Director, who also is joining us virtually, dialing in as well this morning. So welcome to them and to others. Just in terms of a bit of an explanation, obviously we've had our patient story in advance because the patient didn't wish to be live streamed, but it's been a very powerful start to the board meeting and has set lots of thoughts in train and a real context for everything that we're going to discuss today. So welcome everybody. So we've moved to item 1, which is the apologies for absence. We've just got one, which is Peter Barron, one of the non-executive directors. If we move to item 2, the declarations of interest, you've got the paper. If there are any changes, please can you let Jenny know? And if there's anything where you need to declare an interest with anything on the agenda, please do so, and if necessary, move yourself from that discussion on that item. So if we could move on, please, to item 3, which is the minutes of the meeting held on the 19th of May. You've all had them for accuracy. Is there any other points of accuracy which we've not let Jenny know? Anything on the actions list that's not covered? No, thank you. Well, we'll take those as a true record then. Thank you very much. So item 4 is the actions log and matters arising. Is there anything on this? Page 1, page 2, page 3. No, and you've all had the work plan there, and Jenny obviously notified us of any changes to that in the covering email that went out. Okay, so if we move on, we've already done our patient story, as I say, very powerful story this morning. If we move on to item 6, my chair's report, I've already touched on some of this, but I'm pleased to say that since the last board meeting, we went through a very thorough process and have appointed a new associate non-executive, Hanif Malik, and Hanif will join us on the 1st of July, which is excellent news. So in fact, tomorrow, which is great. So he will be joining us at our next board meeting, which is great. So we very much welcome him, and he will bring a fantastic different perspective to the board. Since the last board meeting as well, Mike Cook has announced his intention to retire at the end of August. This isn't Mike's last board meeting, so I'll reserve my opportunity to embarrass him for his contribution at the next board meeting, but it's just to formally record that Mike will be retiring at the end of August. So just to let people know. In terms of since the last meeting, Caroline Flint and I have continued to work closely together, and will do until Caroline takes up her position in September, and she's working with Michelle, and I know been in touch with a lot of the rest of you, so we will ensure a smooth handover as possible. Thanks to Caroline for everything she's doing in advance of starting. I've attended the Whitby PACE Forum, and Pete did a really good presentation on the situation with Whitby and the Whitby Hospital. So I've attended to some patient forums, which has been really good. And as we've just reflected, it's really important to hear from the people who use our services. In terms of external meetings and sessions, it's been a really quite a busy month. I attended the National Staff Wellbeing Guardian event. This is a new post, as you know. Dean is actually taking up the post with immediate effect due to my impending departure, but that is the start of a regional network to get wellbeing champions together, and so Dean will be attending those in future. I've deputised for Stephen Ames and attended a contribution session to the ICS model constitution, which was really interesting. And obviously the guidance has come out since. So, and we've had, I know Michelle will be covering some of that later on the agenda. We also on the Humber Advisory Board had a really good session on mental health, and Michelle very kindly chaired that in her role as lead for the system. But it was great because it was contribution from the whole sort of sector and the whole spectrum of mental health, and very much linked to the health inequalities which are associated with parts of the patch, but also mental health specifically. In terms of the system as well, I've been asked to sponsor a bit of development work on the partnership itself, and I'll update the board as that work progresses. It's just very much at the beginning of that. So are there any questions before we move on? No, thank you very much. So we can move to item 7, the Chief Executive Report, Michelle.
Thanks, Chair. Good morning, everybody, and welcome. I'll just pick up headlines and then I'll leave it to my colleagues, the execs, if they want to pick up anything from their particular section. Just to highlight the Meet Michelle sessions that continue around the organisation. I started these before COVID, and these were just an informal gathering of staff that we could have a two-way conversation about things that were on their mind, my mind, and just to look at how we could work closer together. They're continuing, but virtually, and the numbers are really, really high. We had over 80 this time. We've had sort of 70s to 100 before, people dipping in and out, and they're really helpful. And I found them really useful. So they will continue. And we discuss obviously the challenges, the demand, but also a bit about the blended approach, which is going down very well. And also what we find is that staff are dipping in and out of the board meetings as well, which is fantastic, and listening to what we chat about, which is again is really, really positive. And there are some challenges in there as well, which we always get back to the relevant members of staff as well. And it's generally a relatively good coverage of staff, from corporate staff into frontline staff. I'm just going to touch on very quickly the recovery and restoration work that we've talked about a lot, but we will be having a paper next time. We've launched a couple of things over the last couple of days, and it's in the report. One is the final restoration and recovery plan, which is where we ask staff what would make a difference to them in relationship to being tired at the back of the pandemic, etc. Because if you remember, we've got the Proud programme still ongoing, leadership programme still ongoing, but we've also done a lot of tokens just to say thank you so much for our staff who are absolutely amazing throughout the organisation, from a patient, corporate point of view, etc. And we've done various things like an extra annual leave day, we've done Easter eggs, we've done all sorts of different things to support and to thank staff. So we continue that by asking what would make a difference, and we've got all sorts of great ideas in relationship to a bit of an away day, another development session, time in a park, etc. So we've finalised that now, and that plan has been signed off, and we'll give you a bit of a resume through the workforce committee, but to board. The other thing that we've just launched is the You're a Star programme, which links in, and this is to replace our annual awards. If you remember, we asked staff what they wanted to do. They didn't want an annual awards ceremony for this year, which I think we absolutely all support, because everybody's been a star this year. So we are going to do that, and we've launched it. So that's giving a pot of money per head of our staff just to spend it how they want to spend it, either on themselves or as a team, but then to take some pictures, maybe some videos, and we're going to do a bit of a compilation. So we'll do a bit more of a depth report last time, but that's really exciting. And really, really great for staff, and that's on alongside our capital work that we're doing in relationship to our health and well-being and supporting the environments that our staff work in, specifically in our units as well. The staff health trainer links into that. This is quite a unique post for organisations. This builds on the health trainers, which are there to look at obesity, smoking, healthy lifestyles, etc. And there's now a post being developed for staff trainer to allow just to allow staff to maybe contact that person and just see if there's anything that they want to make, any lifestyle changes, etc. So it's quite unique, and that will build on our staff health and wellbeing offering. Lots of things happening around the region. We're going to come on to a couple of papers later, so I'll leave the integrated care system there until we come on to that. I have given a couple of regional presentations on provider collaboratives and the work that we're doing, because we've seen it in Humber as a bit of an exemplar, but I will touch on that a little bit later. We've got a couple of posts moving, which I've reiterated from Navigo. Jane Lewington, the chief exec, is moving into the chair post, and Simon, the finance director, is stepping into the chief exec post from September. Rob Webster has gone into the ICS full time. If you remember, Rob, the chief executive of South West Yorkshire, was doing both. He's now gone into the ICS on a secondment basis until that appointment's advertised, and Rob may or may not apply. And the Mark Brooks, who I did actually think used to work at Humber. He's been appointed as acting chief executive for now. So there's lots in there. There's a great COVID summary. Thanks to Lynn on that. I will ask my directors if they want to raise anything. Just to note, there's lots of work going on in communications. Continues the awareness days. The coverage is great. You'll see that the positive negative media coverage. And I just want to draw your attention to the NHS Tea Party, the NHS birthday we celebrate every year, the 5th of July. We're continuing to do that this year, and we're in the process. And thank you to our fantastic volunteers. I mean, they are just so marvellous, who are sending out, as we speak, gifts to our staff just to say thank you, have a cup of tea and have a bit of a tea party. And they're in a bit of a tote bag as well with unbelievable on. So they're being delivered as we speak by our fantastic range of volunteers who we could not survive without. So I'll stop there. I know Michelle wants to come in, and I'll pass it over to anybody else at this point in time, Chair, but thank you.
Thanks. Michelle?
Thank you, Chair. Just Michelle's pulled out a couple of things, but it is a very detailed Chief Exec report. So I just wanted to pull out a couple of achievements in relation to our strategic communication and marketing before we move to questions. So just very briefly, the use of our brand continues to remain high, which is testament to the engagement of staff and the ongoing workshops to support staff in their daily work. Website has seen an increase in 25% increase in visitors, and first time increase of 28%, which is fantastic. As noted in the report, we've developed an apprentice role, and we've been delighted with the fantastic amount of high quality candidates and interest in the role. Interviews have been held, and subject to employment checks, we'll be announcing that soon, and it will be a fantastic, excellent training programme for an individual and a great career opportunity. The role will also support those campaigns throughout the year. Two key ones, as briefly noted, were the NHS birthday, which is next week. It's an opportunity for a feel-good moment for staff and a time to celebrate what's good, not only about our trust, but the wider NHS. And as Michelle said, a big one is the staff thank you and September celebration week. Thank you, Chair.
That's great. Thank you, Michelle. John, do you just want to flag a couple of things you mentioned in the chat box?
Thanks, Sharon. Just to flag the research that we've had our annual review with the CRN, which went really well. That's helped generate some additional funding for us. All of that will come to in a report in good time. But just to say, it aligns nicely that we can get some research back into primary care, which was a key part of what we were trying to do strategically, and I know we'll cheer Mike up. And also thanks for folks for joining us on the Veterans Festival last week. We have a QI festival running this week, and I think on Friday we have the usual one of how to learn to fold a t-shirt properly, which always goes down well. So in terms of QI, we are going to do something in August which will be targeted at supporting the children of our staff. So actually how they can tidy their room and stuff like that from a QI framework. So a few novel stuff up Catherine Hunter's sleeve, and I'm grateful for the work she's doing around that.
Thanks, John. I like the sound of that. I'm glad I'm going to get in on that one before I leave. That's really good. I can make sure my children participate. That's very good. Thank you very much. Is there anything any of the other execs want to add before we move to questions? No? Well, I'll start on the list then. So, Hilary, do you want to add something?
Yeah, I just wanted to say that it's not in the report, but just to let you know, so it's only just come in. We've been shortlisted for 4 HSJ Patient Safety Awards this year. So I'll put the details in the next report, but just sort of let the board know.
That's fantastic, and well done to everybody involved. That really is good. That's fantastic. And 4, that's really impressive. So well done. That's fantastic. So I'll start with Mike Cook, please.
Thank you, Sharon. Good morning, everybody. And I am suitably cheered on research progress as ever. Which has been significant in 5 years, but also to hear about patient safety, which we have really focused on in the last couple of years. So delighted to hear about that, Hilary. If I may, just going to section 4 of the report, it's all about COVID, isn't it? But it plays out in a number of ways now. I just wondered, 3 things really. 1, how is COVID and the variation in COVID infection rates affecting us, and are we doing anything around the 19th of July that people might notice? Secondly, in terms of the CAMS surge, I just wondered how that was affecting the inpatient unit. and the PICO opening and the intensive care opening, etc. And thirdly, as part of Restore and Recovery, I was sort of waiting to hear about where's our waiting list sort of initiative. We might talk about it later, I'm sure, but we know we've got waiting list issues. We know there is a big demand on us across our mental health services, and perhaps that is most noticed in child and adolescent and indeed autism and other things. So I just wondered those 3 points. Where are we on COVID in variations locally and planning for the 19th? Secondly, what about the inpatient side? How is that moving forward for CAMS? And thirdly, is there a chance for us to get some Restore Recovery stuff? Great that we're doing all the stuff for staff, but actually, can we get some targeted resources to reduce waiting times?
Okay, Lynn, do you want to start with those?
Yes, thank you, Mike. So on the new variants, obviously what we are seeing locally in line with what's happening nationally is a rise in the rates of COVID in our areas. So, for example, in this report, the rates have risen again over the last 7 days. So Hull's at 50.4 now per 100,000 population, East Riding's at 70.1. So it's still creeping up at the minute. The impact for us is we are not seeing significant rise in staff absences as a direct impact of staff having COVID. What we are seeing is a slight increase in the indirect impact. So some staff obviously being contacted through the track and trace system as being contacts for people who have tested positive, and some impact as well of the impact of schools where children are being sent home to isolate, and obviously that impacting our staff who are parents. It's manageable at the minute, Mike. It's not having significant impact for us, but obviously we are keeping a close eye on that and continuing to monitor it very closely. On your question specifically about impact of the 19th, I'm sure Hilary perhaps might want to comment. We're not expecting to see some of the restrictions that we currently have in place around COVID safe working. So, for example, the need to cohort, obviously COVID positive patients, or a significant change to infection and prevention and control guidelines. So I don't know if Hilary might want to comment further there. On the CAMS opening of the PICU beds and the pressures, Mike, obviously those significant pressures, both locally and nationally, continue to be experienced by us. The CAMS Tier 4 inpatient bed availability remains under significant pressure, and the complexity of the presentations that we are seeing remains very high. And there is a issue impact for us that we are seeing in some of the demand for inpatient beds, which is due to residential placements, particularly for children in looked after care provision with local authorities where those placements are breaking down. And we have seen some of those cases more recently too. What it has meant for us is our general adolescent unit actually has been closed to admissions for the last couple of weeks. It is not fully occupied, but that's due to the complexity of the young people and service users that we have in there at the minute, and that is with the full support agreement of the specialised commissioners because of the complexity. The PICU, I'm very pleased to say, is opening today. And it's opening with taking two actually young people who meet the threshold that are already in our services today. And then obviously we'll look at that and monitor that very closely in terms of how we open the remaining beds from today. Really pleased that we've been successful in recruiting additional staff to our CAM service in order to be able to do that. So that will support some of the pressures that we're seeing, will ensure that those children and young people are obviously in the right place to have their care needs met. But that ongoing pressure is still there in our systems. It's something we're very focused on locally. We're working very closely with our CCG and local authority partners to do whatever we can to offset those pressures. Michelle is working, I'm sure she will say, at ICS level around supporting this as well, because I think it's very fair to say we don't see this pressure demising anytime soon. I think some of us are just concerned that it's going to continue to rise because of the impact of COVID. Mike, you make a very good point around the recovery restore plan in relation to waiting times, particularly in those areas of high pressure, so children and young people again. And I can assure you that there is allocations and actions in that plan specifically targeted at waiting times. So some of that is improving and increasing access to digital platforms to support, and some of that is increasing staffing in some areas to support the trajectories and plans we've already got in place. So I hope that answers the question. I don't know if others want to comment.
Is that okay, Mike?
Yeah. Don't know if Hilary wants to comment.
Anybody else want to add? I'm quite happy with that.
Can I just add a bit about the system about CAMS, if that's okay, that Lynn alluded to. First of all, Lynn, can you just check your mic, because it's a bit crackly. I don't know if it's just, I think Dee mentioned it as well, because I didn't know if it was just me. So do you mind just
No, it isn't. I was just going to say at the end, thank you, Michelle. Yes, your mic is very crackly, Lynn. You could be having a long day, Lynn, with that mic.
And we can hear you okay. It's not, but it would just be a bit off-putting, I think, if we can. So just to have a look. Just to pick up the regional piece, the system piece, following on from Lynn's comment, there is a lot of work now going on from a regional point of view in relationship to children and young people specifically. I mean, there is in mental health crisis anyway. I've just opened another review of the crisis pathway across Humber, Coast and Vale because of emergency admissions, but also things in the emergency departments of hospitals as well. There's a small amount of extra money that's come from the centre around child and adolescent, so we're having a look and seeing how we can utilise that to its maximum effect, because it's not necessarily just about opening more beds. It is about that relationship and the partnerships with particularly the looked after system, the local authorities, etc. So we are looking at that at the moment. There's also a task force that John Lawler is chairing on children and young people that Hilary will be representing us on that, so thanks Hilary for that, alongside others, because it needs to be very clinically led. One of the things I have just called is a surge meeting with all the chief officers, including the chief executives of the local authorities, for next week to talk about how we what else can we be doing in relationship to the surge on children and young people, both now, but for me it's that longer term piece, because the trajectories are still significantly bad going forward. So for me, we need to put the fire out now, for want of a poor analogy, but we need to make sure that we're doing something in the future as well. So I want to really take stock of that. So there's a lot of that, and we'll bring more of that back to the board as we start to have those other. We've had some surge meetings, but this is a chief officer led surge meeting that we've linked into the local resilience forums as well for whole of Humber, Coast and Vale. So I'll keep you posted, but it's a national problem as well. The issue is there's no national beds, which obviously perpetuate the problem, and we've got to think about the children and young people themselves, because they're our main priority. So I'll keep you informed.
Thanks, Michelle. That's really useful. Some good questions there and some good discussion. Hilary, I think you make a really important point in the chat box, actually, about changes, any changes and social distancing for the nation, not the NHS. And I think that's a message that as a trust, I know that we've tried to reinforce all the way through. So thank you for that. So we've got some more questions to come. So Dean.
Yeah, thanks very much. Thank you, Michelle, for a comprehensive update again, and good to see in there that NHS employers have noted the improvements in the staff survey and asked for a case study. So that's a good way of getting some of the work that's been taking place sort of spread more widely, and particularly important because we know that there's a link, isn't there, between staff engagement and patient care and patient safety that we talked about earlier. I just want to pick up, you put something in there about PPE, and apologies if this puts maybe Hilary or John on the spot, but I noticed some research that came out yesterday, I think in Cambridge, about upgrading sort of PPE. I think for COVID, wards rather than sort of in general use. But given it's things that trade unions have raised nationally about sort of PPE, I just wonder if there was any potential implications for us in our organisation about the outcomes of the research or anything that we might want to be doing.
Shall I?
Hilary, do you want to pick that up?
I'll pick that one up. I haven't looked in detail at the research yet, Dean, but obviously that research will obviously influence the government changes, any changes around infection control. There has been something come out in the last week around the use of the FFP3 mask, which are obviously a high level of protection, in that we have to have everybody assessed for using more than one mask. This is so that we've always got enough PPE, because obviously the one type of mask might run out, we might have to use another. So there's a lot of work for us now in having to go around and reassess everybody and make sure that they can all at least wear 2 masks. Obviously, we have a heightened use of PPE on our COVID wards, which we've got the ward in the Humber Centre, and then we've got the pod at Millview as well. So all of that is in line with the current guidance. But any research that comes out, I know is looked at, and it will inform any future infection control. Which, as soon as we get it, we will work with it.
Thank you, Hilary. Anything anybody wants to add on that? Dean, are you happy with that? Yeah, that's great. Thank you. Francis?
Thank you, Sharon. A couple of points. First one, probably to Pete Beckwith on the COVID stuff. Just wondering if he's got a date yet for the opening of the Meister Lodge, which will help ease some of the pressure. With the first one, do you want me to give them all, or shall I just take them one by one?
No, do them one by one. That's fine, Francis. I was going to ask the same question myself, actually. Pete?
Yeah, thanks, Sharon. So internal works are due to complete at the end of July, and then we're just awaiting a final date for the delivery of the modular buildings.
Thank you. Francis?
Okay, my next one was on pack page 39, which was the redesigning adult inpatient mental health services. Great to see that the TVD is ongoing. Are we still on track for that to come to FIC and board towards September, Lynn?
Lynn?
Sorry, yes, we are, Francis.
No, you're still crackling, Lynn, but I'm sure you're working on it.
Dial out and dial back in again, I think, Sharon. Sorry.
Okay, no problem. Thank you. Carry on, Francis.
Next one was on page 40, just to say the pilot that's being undertaken there looks really interesting. Be great to have some update on that going forward. Looks really good. On the international nurse recruitment, I think, Hilary, it says this in here, but I was just checking. What's the ongoing personal support for these nurses once they come across?
We have employed a nurse specifically to support them, a pastoral care nurse. So that they will be supporting them, and obviously there's some items in the report that says some additional things that we're doing, but that nurse is completely focused on pastoral support for them, and is working with other trusts where they bring, this is routine for them, so we're working with the other trusts to find out what the sort of things that nurse needs to be doing, what actually works, what maybe doesn't work, so that when they come across we're ready for them.
Great, thanks for that. And then my only other points we kind of picked up slightly. John, great on the research and the CRN, really well done to you and the team. I love the idea of the apprentice in marketing comms, that's great. And it's really good to see the HPMA awards and Lee Rickles getting the BCS fellowship. It just, again, shows throughout the trust all of the good stuff that's going on. So just congratulations to the team.
Thanks, Francis. Yes, and I think on behalf of the board we should congratulate Lee, because he's doing, plays his part in the system in the trust, and it's a good achievement. So, John, if you could pass that on, or Pete, to Lee, that would be really appreciated. Thank you, Mike Smith.
Thanks very much. So building on that, my first point is about this report and how fantastic it is that all of these things are going on. And of course, when you put a report like this up, and the non-executive directors and others start to ask lots of questions about things. So well done for putting it up. Well done for acknowledging there's still a lot to be done. Well done for just being there, and be kind to yourselves is the first thing I would say. The second one, just the detail points like non-executive directors do. Well done, mental health response vehicle pilot, lots of connections there, lots of potential there. Can I just ask for assurance purposes and what the monitoring of this will be in terms of will it go to quality, mental health, or both, or haven't you thought about that yet? That's number one.
Sorry, Lynn's just dialed off. I'm assuming at the moment, Matt.
Just let me know.
No, Lynn, are you back? I can see you, but not.
Yes, is that any better?
Loads better. Well done.
Did you? I was going to probably, but did you get that question from Mike about the?
Yes, I did hear that, the evaluation and where it will go in our governance structures. So, Mike, yes, we're expecting, obviously, this will be a full evaluation. We've been fully involved in some of the metrics and KPIs in relation to this. So there will be a report at the end of the pilot, and I'll ensure it will go through the appropriate routes. I think bringing it to Mental Health Legislation Committee might be a suggestion, given its connections to the wider system and Section 136 and so forth.
Yeah, exactly. Thank you very much. Next one, Hilary, for Director of Nursing Report, Domestic Abuse Act, new offences, lots of things there that I didn't know about that are really, really positive in terms of helping people, and a link there to the number of NHS staff that may or may not be affected. I'm just wondering how we're disseminating this across the organisation for our front line to be aware that these are actually offences and reportable.
So a briefing's been done by the safeguarding team, which has gone out to all of the front line. Obviously, it's been picked up in our groups as well and discussed in detail there. I think for us, the big push will come when we get that government strategy this year. So we'll have some tangible things to be able to link our strategies and our action plan on as well. So we'll keep it running. It's going into the training as well so that people are aware. So as much as we can, we're pushing it out there. But as I say, we really do need that strategy that starts to make it tangible for us.
Thanks, Hilary. That's it. Any more questions from anybody? Pete, Beckwith, you had your hand up earlier. Is there anything you want to say?
I did, Sharon, but Francis stole my thunder. It was just to make sure that as a board we publicly congratulated Lee on his achievement of becoming a BCS Sub-Chartered Institute of IT. I think it's a great achievement. I saw his application and it recognises all the good work that Lee does, not just for the trust but for the wider system.
Absolutely, thank you. We absolutely endorse that, Pete. Thank you very much. Okay, thank you. Then if we can move on then, please, to the next item, which is the item 8, the publications and highlights report. Michelle.
Yeah, thanks, Chair. And thanks, Mike, for those really nice comments, and thanks to the team and the staff in the organisation, because yeah, we're still on a journey, but we are continuing to make steps forward. So thank you for observing that. Publications and highlight report, just the usual. We've picked out the national strategies, the national pieces of work that have come in that are important. We've highlighted the main ones on the front, and we've obviously just given a bit of a resume about where we're up to and where they'll go in the organisation. But as usual, Chair, I'll stop there and just either answer any comments or pass them over to my colleagues.
Thanks, Michelle. Mike Cook.
Just briefly, if I may, the theme of all this, of course, the ones that you've highlighted, is CQC changing very much its approach, and something we've discussed at Quality, led by John and Hilary, on culturally appropriate care. That seems to be quite an expression being used, and I think it would be good to have another discussion, perhaps at the board, on all the CQC changes. It is signalling a change in approach, and it's important we're in step with it, ahead of it, as you always know is the best. So just a comment, really, a lot about CQC, National Quality Board, all sorts of changes there.
Yeah, it's a great point, Mike, and we have had a conversation about whether we do a board report. So I absolutely agree that that's it, and we'll do it for July if that's okay. We'll get something on, and we're doing some posters and things around close cultures for staff, and trying to make it visual as well as so we can include all that work as well. But really good point. Thanks, Mike, for that, and we'll make sure we add that to the agenda. Thank you.
That's great. Jenny, can we take that as an action then, that we'll do that for the July board? We'll have a session on CQC changes as part of the agenda. Thank you. Good suggestion, Mike. Anything from John? I think you must be on mute, John.
Thanks, Sharon. Instead of just having another report, I'm just wondering, would it be useful to ask the CQC to come and have a conversation with us about some of the changes that they're making, whether it's the Deputy Chief Inspector, because we have looked at the CQC reports. We have flagged the language of closed cultures through the publications report. It has been discussed at Mental Health Legislation Committee, and we have produced some stuff. But I'm just wondering, is just hearing from the CQC directly more useful perhaps than just us reading all of their reports and reinterpreting them for ourselves again? Just a thought on that.
No, I think it's a good suggestion, John. Who's going to facilitate that then? Who's going to try and facilitate them coming? We could do a session after the board, if it's possible, in July.
Time might be. I am meeting Kevin Cleary on Friday again as part of the national work. So if I get 5 minutes, I can ask him at the end of that. If not, I can ask Brian Kramer, who's I've got a meeting coming up with him in the next couple of weeks, who's our regional inspector. So I might hand it over to my colleagues, but I'll make some tentative inquiries if that's okay, just to kick it off. Only because I've got meetings coming up.
No, that's really helpful. Thank you very much. Good suggestion, John. Anything for anybody else before we move on? No, thank you. If we could then move on to item 9, which is the performance report, Pete.
Thank you, Sharon. So obviously this is the month 2 performance report. So this is our performance as at the end of May. It's the report we're now accustomed to. So, using statistical process charts, and we've included on the front sheet commentary for those indicators that fall outside the normal variation range. I guess if I put some highlights in, then we can move to questions. So we're seeing continued strong performance in our training overall, and we've crept above 91%, which is great. We've also started to see a reduction in our longer waits, and there is a separate appendix to the report on waiting times. We discussed out very briefly in Michelle's Chief Exec update report, and we know some of that's impacted on the waits that may still lodge, but those capital waits are progressing. And I guess as your finance director, whilst it's still in normal variation, you'll notice that for the I&E graph, we've now moved from the static straight line we've had for the last 13 months. And we'll pick this up a little bit in the finance report, but that's to reflect the ask from the ICS for us to deliver a small surplus in the first half of the year. So just some of the key highlights I picked out of the report. Chair, I'm thinking we stop there and just move to questions.
Thanks, Pete. Lynn, would you mind just covering waiting lists? I know there's some really positive movement in the waiting list situation. Some of it's detailed on the front sheet, but could you cover CAMS in particular and anything else that you'd like to highlight, particularly given our patient story this morning? It'd just be nice to pick out a couple of pertinent points, I think, because there has been some movement. Thanks, Lynn.
Thank you, Chair. Yes. So obviously we've continued our work around all those areas where we have got still over 52-week waits, particularly. And unfortunately, as we've been discussing here for quite some while now, unfortunately, autism, paediatric children's autism, fits into that category where we have got over 52-week waits. So in the appendix, it details the progress, particularly for autism waits in our CAMS service. And I think it's very fair to say what we are seeing now is a improvement now over 3 months. So it's steady progress. That work is being led by my Deputy Chief Operating Officer, Claire Jenkinson. She's got a range of operational mechanisms in place that oversees that work. Obviously, we have looked at the pathways, the processes, and really the resourcing of those waiting times as well. So back to Mike's key point earlier, we are using, where it's clinically appropriate, a digital platform to support the autism pathway. That's in place now and has been since May. That's making good progress. Obviously, our clinicians are looking at the outcomes in relation to that, and there is the capacity to increase the use of that particular platform too. So we are planning to do that as part of the recovery plan. And we have looked at additional resources as well in relation to that. So there is part of the recovery plan is focused on increasing the number of psychologists who support the diagnosis pathway, particularly. So it's great to see that we are making progress. If I'm honest, I think there's still a little bit capacity to improve the rate of improvement there. So that is the focus of the work that we're undertaking now. In relation to wider CAM services, particularly Sharon. So another area of focus for us is the ADHD, which has significantly fewer young people on its waiting list at the moment. But there are a few of those, not very many, that are in the over 52 week category. So again, we've got plans in place to address those. And then I guess the other area that we monitor very closely is the core CAMS service, as we describe it. So not the neurodiversity pathways, but the core CAMS, where we don't have any over 52 week waits. And we still do have longer waits than we would want. All of those waiting times are within 6 months. And the average for those, certainly in some areas, is less than that, obviously. And obviously there is clinical prioritisation that takes place as a triage process at the first point of referral. So obviously where service users, young people's families' needs can be met and signposted elsewhere, and that is a robust process now, supported obviously by us. There are other providers that support that too, both the local authority and Mind. So again, we've looked at all of those processes recently to make sure that they are working as effectively and as efficiently as we can. We have identified some further work around there as well. So working closely to ensure that, you know, we really are optimising all the resource that we have. We've already touched on some of the pressures around our children and young people services at the moment. So it's not just an issue of numbers in terms of demand. It is that picture of complexity as well that Michelle and I have talked about already, and we are seeing that obviously in our community core CAM services as well, with that pressure for particularly inpatient beds and the lack of availability of those. Obviously we're really focused on ensuring that our community services are as responsive as they can be. So we have been able to expand our CAMS crisis service to a degree. We're still talking with commissioners around how we continue to do that further as well, really thinking about, you know, the pressures that we've got now, but, you know, as we've already talked about, that, you know, with that surge not being expected to reduce anytime soon. So I'm confident we've got the work in the right place to address those pressures, and we are monitoring it very closely. There is further improvement work that we're undertaking, as I've said, but I'm really pleased overall that the steady progress is there, and we are going to build further on that. So I'll pause there, Sharon, but happy to take any further questions around that.
Thanks, Lynn. Can I just suggest we just take questions on waiting lists, if there are any, before we take them on the rest of the report, just so it flows better. So, Francis, have you got any questions on waiting lists?
I was just going to compliment the team on what they've been doing, and was pleased to hear from Lynn that she's still got plans to improve it. So I wasn't going to ask a specific question, but obviously because we ask about this every month, and I normally drive one of those questions, I just thought I'd again acknowledge the work that's ongoing, which is good to see.
Yes, and RTT incomplete pathways have improved as well, Francis, haven't they? So I know that's one of our favourite questions. Mike, have you got a question on the waiting list?
It is, and then I might link it to another point if I may. But I did do a little bit of my own homework. So there's two trajectories in this report, which are I think are really helpful. And I do sense there's a grip on it from your team. If I look back, say, it might be 2 years ago, I think we're down into 200, maybe getting towards 150 over 52-week waiters in total. We've now got 1,432, according to my figures, but that I may have. And we took 61 off that, which is good, but actually, is that the right trajectory in the circumstances, particularly when we're looking at restoring things? So I go back to the earlier point, really, you know, are there ways we can get the system to help us improve that really hard-won progress, and our own clinicians working differently and working with others in different organisations. So that's the point, really. It's 1,400 people over 52 weeks, and I've been considering that's not a service, you know, and we need to really try and restore what we can as quickly as we can, and support you in doing that. So that's the point on waiting lists, but I wanted to triangulate that with incidence, high sickness, turnover, and potentially morbidity and mortality, because it's that analysis that we also need to be looking at.
Okay, thanks, Mike. Lynn? Might be helpful to remind us, I think some of the waiting lists we inherited, didn't we, along the way, in terms of it's just not been a gradual. I know that we took lists from other people, didn't we? So might be helpful just to recap some of that, Lynn, and then respond if you don't mind. Thank you.
Yes, no, thank you. Sharon, thanks for the question, Mike. I think it's really important, as you say, we do triangulate this information. But yes, we have had some step changes, unfortunately, along the way for very good reasons. So the autism diagnosis waiting list was, there was a step change, some of you will remember, due to a change in the arrangements for one of our other providers, where we took on circa 400 additional cases. And obviously we had to do a lot of work around that. We did do some clinical prioritisation, but the impact of those cases obviously is it did enhance our waiting times. So it hasn't been a stable, static position, unfortunately. But I think, Mike, you know, what we do need to do, irrespective, you know, now, and I'm pleased that you've acknowledged it as well, that, you know, we have to see that, because we have had periods of time, if I'm, you know, completely honest, that we have seen improvement previously, but then that improvement has not been sustained. So I am sort of giving a positive report overall. I think what we're seeing now is the depth of systemic operational work that's needed to take place in order to sustain the improvement and recovery. And I think we are doing that and undertaking that, working with the teams to do that. But there is still a bit more to do for the reasons that you've already acknowledged. So if we do have a position where if we have a higher level of vacancies, for example, in our CAMS community services, than we would wish to see, we are targeting that at the minute with particular bespoke recruitment campaigns. And I guess to some degree we have seen some increase in sickness absence as well, the pressures, and that's what, you know, it's important that we balance consistently, is the impact of those pressures obviously on our staff and the need to ensure that we're supporting them adequately at work. So I think through the various plans and mechanisms that we have in place, you know, for me, it's why the health and wellbeing agenda is so critical to our recovery at this point in time. But CAMS, you know, really are at the sharp end of that clinical complexity right now. So I think it's important that we continue to look at that service in terms of what it needs in relation to supporting our work there. In terms of incident reporting, obviously, Hilary, John and I have oversight of that. Hilary, I don't think we're seeing anything particular at the minute that is concerning us. In fact, our incident reporting, we're pleased with what we see, particularly in relation to Inspire and their management of incidents overall. Something that Hilary particularly, but I too and John look at very closely. But obviously, given the pressures and complexity that we're all describing today, an area that we need to continue to make sure that we're focusing on. In relation to mortality, I think, John, might be useful, given your oversight of that, to bring you in, if that's okay.
So, Mike, just in terms of mortality, we are bringing a paper to board which will review all of the COVID mortality as affects the wider organisation. So that piece of work has been done, and we're just doing some final inspections on it before it comes to board. I don't know if you want me to pick up the COVID Delta variant mortality. We do know that it's more infectious. We're not necessarily seeing a rise in hospitalizations. But that's probably related to the fact that the vaccine is doing its job, in terms of that phrase of a vaccine wall. And I think one of the things that's slightly different this time round is actually probably the removal of masks from children in schools has probably led to this wave being worse than it perhaps could have been, if we're being honest with ourselves, because we're certainly seeing a spread in younger people amongst children, and that is spreading out to their parents. And actually we're seeing some of that with some of our own staff, and people who are getting pinged when it was previously quiet. So
We are where we are with the Delta variant, but it doesn't change the fact, as Hilary alluded to, that it's all about the IPC controls, which we've had in place right from the start. I think there is something about, to pick up Dean's point about the FFP3 masks. I think the NHS needs to act on that probably pretty quickly, because the evidence from the research, I think, is reasonably solid. And if anything, it's what staff want as well. And the final thing is just encouraging people who have not been vaccinated, whether they're NHS staff or whether they work in health and social care or whether they're aged over 18, just to come forward and to get vaccinated. And I think the NHS has done a pretty good job in terms of the grab a jab over the past couple of weeks. Some of you who follow me on Twitter would have seen that our own surgeries up in Bridlington, which is an area of health inequalities, being on the coast, and we know that. And our 3 surgeries were collaborating together on Saturday morning. And it was brilliant to see queues of people around the corner going into surgeries, particularly younger people, to get vaccinated. So clear evidence there is that the anti-vaxxers and all of those kind of folk aren't getting much traction when we present people with decent science and decent evidence. But I think this evidence needs to be kept within the health and science space, as opposed to perhaps other space. And that's the best way of convincing people that it's the right thing to do to come forward and have a vaccine. And we're still working hard internally, just making sure we've got the recording right, particularly of lateral flow testing, because that still has a very important role to play in terms of picking up infection. And I just say we're not taking this lightly at all. We're treating it very seriously. But to pick up the point is, I think people, particularly across our services, are tied, and we are seeing an increase in demand and acuity. So we just have to balance all the competing priorities. That's really helpful, all of you. Thank you. And great that Hilary, Lynn, John are working closely together. Because I think that things have changed a bit. You know, the fact everybody's vaccinated or there's high levels is fantastic. But actually, there's obviously something going on in terms of how it's vectored now. And so well done to you all. You know, I think it's just trying to support it perhaps at quality. I know we're going to see the mortality report. We're looking forward to having a good look at that. We can triangulate across where those areas of high sickness, incidence. There's actually a slight increase in turnover again. It's just those sorts of things where we can have a look at the overall picture together. Thank you.
Okay, thank you all. Mike Smith, is your question on waiting lists or something else?
Something else, Chairman.
Okay, well, if I can then, Lynn, just finish off on waiting list and we'll move on to everything else. The appendices are really useful attached, well, I find them useful attached to the performance report, so thank you for doing those. Just in terms of the figures, because obviously for obvious reasons, this only goes to the beginning of June, and obviously some of these measures that you've described were only implemented quite recently, but just in terms of the numbers of over 52 weeks, are relatively small reductions because of all of that in this. It's just assurance that we're still seeing, I mean, and it's another 3 weeks later, but we're seeing that trajectory continue, really. That's my question.
Yes, it's absolutely, Sharon. I get the figures at least once a week, if not more frequently than that. So I can assure you that we are still seeing week on week improvement. Believe you me, if we weren't seeing that, then obviously I would be taking steps to address it. So and as you say, you know, we're doing more to expedite the rate of improvement as well.
Perfect, thank you. Right, Francis, your other questions?
Thanks, Chair. There was a couple, and one of them picks up on Mike's, but I'll come to that in a second. The first one was was around the safer staffing dashboard, and just where are we with Inspire and Millview now? The good that we've had an update. It's great to have that in the exec summary. Is there any further updates since then? I'm guessing that's still
yeah. Inspire and Millview in terms of which indicators?
The clinical supervision that you've got on the exec summary on page 63. You talk about being below compliance, but the general trend is upward.
Yeah, the upward trend is the latest figures from the report that came out last week. Millview, Lodge and Westlands are the ones that we're watching at the moment, where the figures are dropping in the latest report. That obviously the board haven't got those figures at the moment. Got the matrons onto that to find out, you know, why, and get some more support in. It's what we would expect. It's sickness, it's absence of leaders. Sometimes, you know, the charge nurse being off sick as well. General acuity. But again, as Lynn and I always say to them, it's really important that when the services are under pressure, whether it's sickness or acuity or both, that clinical supervision in some form or another is absolutely there to support the staff. Everybody gets that and gets the importance of it. So we're constantly on that with them. But we get the monthly reports. And as I said, those are the two that with the current one that came last week that we're watching. Inspire is continuing to increase its compliance. So it's getting there.
Thanks, Hilary. My next one was kind of where Mike was. So I've linked together pack page 68, which is vacancies, pack page 71, which is the dashboard and sickness, pack page 87, which is sickness, and pack page 88, which is turnover. And if you link all of those together, it kind of brings Mike's point to life, because all of those, it's only slight upticks, but all of them are showing a slight uptick in whether it's in vacancies, whether it's in sickness, whether it's in turnover. All of those are just starting to tick up. And it's just a warning sign. I think it's, as Mike said earlier, that we just need to pick up on, and whether we deal with it here or whether we deal with it at Workforce Committee, but it's just a slight warning sign. There's great work going on in supporting staff, but obviously it's beginning to now start to have an impact, and you can just see a slight change there.
Thanks, Francis. John, did you want to respond to that? You're on mute.
Hi, Francis. I think you make an interesting point. I think, in fairness, if we look back at earlier boards, we did predict perhaps 6 to 9 months ago that when we kind of started to get towards the finishing line, if there ever is a finishing line with this stuff, that all of those metrics would start to go off, Francis. It doesn't surprise me. It's what you would see in the military environment after a long tour. People just run out of steam. I'm pretty confident we're trying to do as much as we possibly can as an organisation. We've talked about the Eurostar awards, we've talked about the recovery plan, all of those things that we're putting in place. But ultimately, I think what we're trying to do here is mitigate things from getting worse as they possibly could be. So you'll never get praise. You'll always get sort of criticised for things getting worse, but actually the trajectory of things getting worse is what we just need to watch. And I'm confident that no stone is being left unturned, particularly when it comes to resourcing from Pete and others to try and mitigate some of these things. But this, I think, is an inevitability, Francis, with regard to some of those workforces metrics. And it is just a question. We have to be realistic about how we mitigate some of that.
I agree with you, John. I think the work that you and the team have done has been fantastic, and all the work that is ongoing now. It's just, as you said, I'm not sure we're even close to the finishing line either. It's just showing the start of an uptick, which we just need to be aware of.
Thank you. Michelle, did you want to come in on this point?
Yes, I will. I mean, thank you. I mean, it is really a really useful conversation, and that's the beauty of SPC charts. It is easier to correlate, and I do think it's something for the Workforce Committee. Just a couple of word of caution. I mean, that's why we're doing a lot of work on the restoration and recovery plan and supporting staff health and wellbeing, and we'll continue to do that. A lot of it is predictable, and relationship, as John said, as we come in, we're still in the pandemic. Let's be really clear about that. I mean, I know there's still a lot of feeling that we are hopefully nearing the end, but we're still in the pandemic. But there are some issues in relationship to rotation that do affect the figures in relationship to the turnover. We always, at certain times of the year, we get higher turnover because of retirees, etc. But I think it's quite a useful one to have a conversation at the Workforce Committee, and then we can maybe have a discuss there, and then just say, well, what's the outcome in relationship to quality? Is there any reflex? And maybe then take that into the Quality Committee, because as we know, there is a correlation. But I think I would suggest that maybe we get the Workforce Committee just to do a bit more of a deep dive on that.
Yeah, I think you'd be good.
Thank you. We'll take that as an action then, Jenny, please, that the Workforce Committee will do a deep dive on the triangulation issues that have been discussed and raised. Francis, did you have anything else? Thank you for that.
One final one was just the out of area placement days, because I know we're doing work on it, but again, the gap continues to widen between what we'd aspire to and where we're going.
Yes, and I think the narrative does explain a lot. That's to do with Meister, doesn't it? But we've discussed that already. Yeah. Again, one to monitor. Is there anything you want to add on that then, particularly that is not already covered in the report?
And just to add on that as well, obviously we despite our pressures, our intention obviously is, and the NHS plan requirement is to continue to focus on eliminating out of area placements. So we do have an operational plan that we're constantly revising around what we're going to do to achieve that. I can assure you that the number of out of area beds that we are using at the moment continues to match the number of fewer beds we have available in the trust, obviously due to cohorting arrangements, so forth, the issues that we've discussed here. So we're still continuing not to use any more beds than we would ordinarily use at this time of year, but unfortunately a number of those are out of area. So we are obviously progressing our plans to address that, Sharon, I can assure you.
No, thanks, Lynn. That's really helpful. So does that answer your question, Francis? Presumably it does.
Yes, thanks.
Thank you very much. Michelle, did you want to come in on this point?
Yeah, from a systems point of view more than anything else, Chair. I mean, it is something that we do need to forensically look at, because from a system point of view, I'm going to be putting pressure on the organisations in relationship to out of areas. Yes, there is a lot in relationship to cohorting for COVID, and there is a slight change in the definition. So we may start to look at the definition if people are transferred in our region. And in Humber, Coast and Vale, if they've got an adequate transfer plan. So I think it is a really useful question. It's something that we need to look at forensically, which I know the ops team are doing. But as a board, we do need to keep a very close eye on it, because they will come under more and more scrutiny from a system point of view.
Thanks, Michelle. Mike Smith, we'll come to you for your questions, please.
Yeah, it's on the out of area placements. And I'm just querying, this is based on some of the work we do in mental health, whether this gives us the full picture, because Lynn has explained to us that the number of beds that we use is still the same. But let me give you an example. If we had a patient out there who'd been out of area for 100 days and they were repatriated, which is wonderful, because that would have a great effect on the figures. If we got 3 patients out there who'd only been out for a week, and they all came back, we'd see the figure drop by 21. We'd have 3 patients back in the organisation, but our patient days would only look like marginal improvement. So I'm just thinking there might be some better ways to present that data in terms of presenting the real picture. That's not a criticism, but it's based on what we see in mental health ledge, that you see an enormous spike in seclusion and you say, well, it's all one patient. And I just think that Lynn's made a really good point, that I'm not saying that it's a good thing that patient days are going up, but beds aren't. So is it worth looking at, Lynn?
I think that's a really good point, Mike. In terms of accurately presenting the data, as you say, actually bed days are important, but the number of patients and how quickly they're repatriated are important as well. So in terms of a clinical quality and safety point of view. So I'll take that away if that's okay. Maybe have a conversation with Pete and the BI team around that. We do have it for operational purposes broken down in different ways as well. So probably that data's already there, Mike, but good question connected to Michelle's about board oversight of this important issue as well.
Okay, so well, thank you very much. Good point. So Lynn will take that away and consider with colleagues as an action. John, on this point?
Yeah, just on this point, I think everyone will have been aware that the National Confidential Inquiry reported on terms of suicide and self-harm prevention last week. And actually nothing has changed from their perspective with regard to what are the 10 key steps in terms of reducing suicide, and being out of area is one of those risks, and we're mindful of that. And undoubtedly this is one of the adverse effects of the pandemic for us in terms of becoming, unfortunately, having to send our local people out of area because of infection control procedures, amongst many other things, whereas normally we support other parts of the system, particularly in LD and stuff, with bringing people in to provide care when other areas have been struggling. So we're acutely aware of this and the impact. We see it on our wards with regard to out of area placements and people who are struggling, and it's something that we're really keen, but we're slightly stymied by the estate. And if we decide to go a little bit gung-ho in terms of infection control, all of a sudden we have an outbreak on a ward, whether it's amongst patients who are vulnerable or amongst staff who may be vaccinated. And then if anything, your out of area bed days gets worse, because we have been at extreme end in terms of operational pressures, particularly in the last week or so. So it's not always a simple solution here, and that every risk we take with regard to bed days has potentially an adverse outcome if we get it wrong in terms of infection control.
Thanks, John. Dean, can we move to you for your questions, please?
Yeah, thanks very much. It was just coming back on the workforce stuff and the deep dive. So Steve and I have been looking at areas to deep dive at the next committee, and we'll take that on board, and that will help us understand it. But I suppose it's just a note of caution, really, is whilst from a workforce point of view, it can help us understand, and we can check if we're doing everything we possibly do. Workforce in this situation can't be the only variable. We have to have a loop back once we understand the issues to say, well, what does that mean for services? What does that mean for finance? If we need to be spending more, for example, on agency or other services to sort of support staff in their health and well-being. So I suppose I'm just flagging up really that we can't just look at the workforce as the non-variable, and keep the others services going. So we'll no doubt loop back in again in terms of things like quality, service planning and finance.
Michelle?
That's a really good point. One of the things that I think that we should mention here is that we're doing a massive piece of work about increasing our bank, because we are, if you look at the agency report, I know Pete says to me, we are using quite a lot of agency money. So obviously their first priority is to maintain our staffing position, and we do that quite well. So again, thanks to the operational team. I know that they work really hard to keep our figures up to what they should be, and they are good in relationship to staffing figures, so thank you for that. But we are doing a massive push now on bank and increasing our bank capacity, which is proven to be really positive. I don't know if Steve wants to mention anything about that, but so there's lots of other things going on, and I think you're right, Dean, it's about looking at that wider picture. Yes, this is the data, how is it relating to quality, but also what we're doing. I also had a really good conversation with the ICS lead yesterday, just to say if there's anything else we could be doing collectively as organisations around bringing people into the area, moving people around systems, why are people leaving, etc. Can we bring them into our organisation for a different experience, etc. So I think there's lots more creative ways of trying to increase the staffing, and obviously our use of apprenticeships now is great, and being an anchor organisation. So I think we just need to look at the full picture, and I think that'll be a really useful conversation. But if Steve wants to add anything about the bank, because I know that we're really pushing that at the moment, and that'll be really positive. And that's across, and we're also looking at a joint bank with North Yorkshire and York in Malton, because that's one of our particular hotspot areas for bank staff. So we are, as I say, trying to work collectively as well. Thanks,
Michelle. Steve, would you like to add anything?
Just to echo what Michelle said, in the sense that, we're looking to grow the bank. We're always trying to incentivise people to come onto our bank and work flexibly. I think it's really important that we link this back into the recovery work that Michelle mentioned at the very start. So when we set out about recovery, we talked about staff recovering, but we talked about services recovering as well. So some of the actions that are within that plan are around extra resources to bring people in, extra bank usage, extra agency usage to help address waiting lists. So all of that's really important. I think it's going to be, again, picking up some of the themes that we've talked about previously in Workforce Committee. Our approach to being flexible to our staff is going to be critical here. So when staff are at that point where they're thinking, I'm really, really tired, and I'm at the point where I'm maybe thinking making career decisions, how flexible we are at that point. So saying to someone, have 6 months as a career break, but come back to us rather than just leaving us, might be the difference between us being able to get through this. So the recent work that we sent out around promoting all the different types of flexible working that we've got, which I circulated recently. Really important that we do that. Really important that we listen to staff about what they need when they're going through this next 6 to 12 months, so that we hang on to as many staff as possible and support them through. And that's why it's great to see what we've done with the recovery work, the investment we've put, and all the work that Michelle mentioned earlier, because all of that is linked to doing what we can to keep our staff. And let's be honest, if they attract staff that may not be getting that support elsewhere in the system. Thanks, Steve.
Thank you very much, and thanks, Dean. Yes, but I think you're absolutely right. Michelle's reinforced the fact that it's a wider discussion, but if you could start that discussion at Workforce as agreed, that would be great, and then feed it back into the wider discussion. That'd be really helpful. So thank you for agreeing to do that. Okay, is that all on the performance report? Okay, I think we'll have a 10-minute break. Adam, can you just stop live streaming? Board members, can you just hang on until we've stopped live streaming just for a second, please? Okay, welcome back everybody. If we could carry on, please. If we could move to item 10 on the agenda, the finance report, Pete.
Thank you, Sharon. So this is the finance report as at the end of May. I think it's important to remind the board for the period April to September, we continue to operate under the block funding arrangement that operated last financial year. And you'll notice from the paper that since the last report to the board, we've had an efficiency ask across the ICS to meet financial planning targets. What that means for the trust is the trust have been asked to deliver a £315,000 surplus for the first 6 months of the year. And I guess I'd be seeking the state to update our plan to reflect that. Some highlights from the report, Chair, then we can move to questions. So at month 2, we recorded a £129,000 surplus, which is consistent with what the ICS are asking for us. Other quick highlights, just to point out to the board that the figures in the report are gross due to the current governance arrangement. So you may notice some slightly different numbers in the FIC assurance report a little bit later on the agenda, but that's because we do a bit of a more net review within the Finance Committee. At the end of month 2, we recorded 1.3 million of COVID items, so that's income top up and COVID expenditure, and that's covered by the block funding we receive. You will note from the table in the report, we have made a small provision for the budget reduction strategy profiling at month 2, so that's a good position to be in, and our cash balance remains healthy. We no longer report the underlying cash balance because we've had no capital receipts of funding in the first 2 months of this year, which we haven't expended. So you'll recall last year we'd often talk about our underlying cash position because we'd often have a timing difference between funding approved and then being expended. That's no longer the case at a material level for it to reflect what we're reporting as a cash position, Chair. So I'll stop there. Happy to take any questions on the paper.
Thanks, Pete. And at my request, Pete did circulate around the agency spend to board members, and that'll go in back in the report again next month as usual now. So any questions on the finance report? Nope. Okay, thank you very much for that, Pete. If we can move on then to item 11, which is the Finance and Investment Committee Assurance Report, Francis.
Thank you, Chair. Obviously, this reflects the same period that Pete has just talked about. So I'll just pull out a couple of items, and then there's 2 things, one a recommendation to board and one a request for delegated powers. So the issues I'll pull out, which Pete hasn't in the finance, is the insight. You can see at month 12, Humber, Coast and Vale recorded a 2.1 million surplus compared with a 7.8 at month 11. So obviously it's come down somewhat since then, and there's an explanation as to why there. The committee complimented the finance team on the excellent work they've done on our debtors. They brought the debtors down quite considerably over the last 12 months, and we wanted to acknowledge the good work that had been done there. We looked at the update on the estate strategy, and I put into there a summary of the key things that have been going on in there. And we had a discussion around Bridlington and where we were going with Bridlington and the various buildings we have there. And then we also picked up on the annual non-clinical safety report from Paul Dent, who gave a really good presentation and talked us through it. And we're happy to recommend the report to the board for sign off. And then finally, we had an update on the application to phase 2 of the public sector decarbonisation scheme for a SALIX grant. We've been offered the money, which is excellent. So the full amount of 1.74 million for the decarbonisation of ERCH and the Humber Centre. But because of the way the timescales work, we need to get this signed off before the next board. So we're asking for delegation from the board to FIC for us to be able to sign that off when it comes through. You can see some detail there, and I'm sure if anybody's got any questions between Pete and I, we can add any extra information that people want. That's it. Thanks, Sharon.
Thanks, Pete. Is there anything you want to add?
Just to cover this, the SALIX grant, which Francis mentioned, Chair, it's just due to the timing of the tenders come back in July. Obviously, it's a 1.7 million grant we need to expend this financial year, so we're seeking delegated approval for FIC via EMT to accept the tenders and then bring that back to board in September for ratification.
Thank you both. Any questions on this? No, very comprehensive. Are we happy to grant that delegated authority? Oh, sorry, John. You're on mute, John.
Sorry, thanks, Sharon. Just one question on the Salex, Francis. It's great to see this investment coming in. Are there any risks attached to us that if we don't spend all the money that we have to give it back, or is it just anticipated that will happen as part of the plan? So, because the delivery is always going to be difficult, particularly with regard to COVID. We don't know which way it's going to go over the next couple of months or so.
I'll let Pete pick up on whether we have to give any money back. I mean, the only other risk was not so much a risk, but we ourselves will have to expend some of our own CapEx, which is around £250,000 for each location, to do some works there. So there is some of our own capital that we'll have to spend on top of this, which comes to about £500,000. In terms of giving the money back, Pete, can you answer that?
If we didn't do the work, we'd have to give the money back, John. As long as we complete the work as per the grant application, similar to other issues we've had with other grant applications, then there would be no need to claw back. I'm confident that if FIC approve the tenders in August, then we'll be able to get the works completed, because quite a lot of it will be external to the building. I'm not worried so much on being able to demonstrate expending the cash. And in terms of the commitment for the rest of the sites, that takes us over the next 2 years capital programme and is scheduled in as part of our 3-year capital planning.
Okay, thank you. Good question, John. So on that basis, are we happy to approve the request to delegate authority to the Finance and Investment Committee to sign off the tender with ratification coming to the board in September, as per the paper? Yes, any dissensions? No, thank you. Thank you very much for that. If we could move on to item 12, which is the Quality Committee Assurance Report and April minutes, Mike.
Thank you, Sharon. The Quality Committee, we're talking about the 2nd of June meeting, this assurance report, and you've got the minutes of the 7th of April for information too. Interesting, we talked about the quality improvement journey for Inspire, our child adolescent mental health inpatient unit, a year in. That was a good and timely conversation, quite a dynamic environment, as we've discussed earlier. And I'll come back to the issue we wanted to just escalate and did. We went through the NHS commissioned investigation. Kwame Fofe took us through that report, which we had looked at a board, but we looked at in more detail at Quality. And similarly, we had a chance to look at the recovery strategy with Lynn, the recovery framework, and welcome the implementation emphasis of that. We also looked at clinical skills competency, and that was something that Hilary and Sam had introduced in terms of some rigorous work around those skills that are required and how you remain competent in them. And we did some good work on the quality accounts. We saw the first draft, the research and development update, which goes from strength to strength. Also clinical audit, and I thought that was a really insightful piece of work. Led by Tracy, actually, who'd done some really good ward-to-board sort of teams, ideas and work. And we also got good assurance on controlled drugs too, via Wheelat and John. So some really good regularity work going on, as well as some of the more developmental stuff. We going to audit last week. I went to the audit committee, and we're just going to have a look at the clinical governance audit findings on the report at our next meeting, along with the highly commended look at mortality using some public health expertise with John. So that's coming to next time. The risk at the time of early June was about the high acuity of young people, the demand for inpatient beds, and the opening of our own intensive care unit as part of the Inspire programme. And we just asked the exec team to look at that. So that's what we covered. Hilary and John, anything else you want to add? You're on mute, Hilary.
Quality Council out at the moment, say for stakeholder feedback, so they'll be coming to the board, as we say, in July. I just wanted to say that in terms of the clinical audit, to really get that embedded and get people the skills, we've put an awareness session on for staff, which is today, and over 200 staff have signed up to go to that session, which is just fantastic. I didn't think there would be that much interest. That just shows you that there is that interest around using that as a quality improvement tool, being able to assess your practice and work with those clinical standards that we want to get embedded in practice. So that's fantastic. So we'll get the feedback from that first session and then see, you know, if there's any tweaks or anything we need to do going forward. But the appetite is certainly there, which is so positive.
That's fantastic numbers, Hilary. That's amazing.
Unbelievable in the current climate. Yes.
That's really
yeah.
good.
I just want to add to the audit piece, actually, because historically we use and think about audit, particularly as a board level seeking governance. Actually, audit in clinical circles is very much around improvement and professional intellectual curiosity. And I have to say, we, you know, perhaps our clinical audit stuff wasn't in the strongest of place 2 or 3 years ago. It takes time to turn around, but it was really positive to see that role of audit and the engagement of clinicians in audit. There's still work to do at the last quality committee, because other organisations have demonstrated through, you know, clinical audit, people being curious, getting involved in improvement, you can drive the change that you need, not just for staff, but importantly for patients and carers. So I think, Hilary, it's great to see that audit team on the way up again.
Thank you all. Any questions on the report? No, thank you very much for that. We're staying with you, Mike, moving on to the Charitable Funds Committee Assurance Report.
Thank you. So item 13, charitable funds met on the 18th of May, and you've got the minutes of the 31st of March. We approved the 60,000 for the Whitby Gardens Enhanced scheme, and we followed up usefully the impact appeal and the sort of residual amount that was as yet unspent and how that was going to be spent. It was all accounted for, and it was useful to have that. So in terms of Whitby and the impact, I think following up on that was useful. And we made a few commitments around how we're going to work together as Charitable Funds Committee going forward. So not much else to say. It was a useful meeting and quite timely, I think. Steve, anything you want to add?
Thanks, Mike. Yeah, no, I thought it was a really useful meeting. As Mike said, we got some business done there. We also had an update of a significant number of requests that had come in for spending to support patients, particularly, and I think that was well received by the committee. So yeah, no, I'd endorse what Mike said, and it was a really positive meeting.
Thank you. Do either of you want to mention, just because it's mentioned in the report, anything specific about the CAMS bill, the 82,000 CAMS bill, or is that just fine as noted?
Sharon, I think it was just a timing difference. Sorry, Mike, it was a timing difference between when we'd issued the invoice and when it was expended and paid for by Smile, because obviously we incurred some of the charitable funds expenses as part of the main project and then recharged to Smile, and there was just a VAT technical issue we wanted to resolve.
No, that's fine. I just wasn't clear what it related to, but thank you.
And Mike, I think might want to come in.
Mike Smith.
Yeah, I just wanted to congratulate the work of the committee, but the whole of the team across the organisation for the holistic approach that they've taken. We've got various strands. We've got Charitable Funds Committee, got a sub-strand with the Chief Executive's Fund and the support that she gives personally, the money that she raises. And we've got the Hey Smile Foundation and specific appeals. And we've also got the Trust as a whole, really looking after its staff. And what you've got is this multifaceted approach And then I think at a previous presentation, Hey Smile said about moving the charity from grant funder to strategic partner. And through that approach, via the Chief Executive and via the work that's done through the NHS Exchequer funds, I think we've got a really, really good approach to staff and patient well-being that's very rounded in its nature.
Thanks, Mike, for that. Francis?
Thanks, Chair. I'll echo all of Mike's comments. And as we're signing off the minutes from the previous meeting, just for a quick point, on page 129, in the first major paragraph starting Miss Poxon, if you go down towards the bottom, it's 1, 2, 3, 4 lines up. It says he asked for clarity on whether we are, if we are. That doesn't make sense. I think we need to remove the words for clarity on whether we are. It should just read, he asked if we are going to fund them in advance and the team will try and raise the funds to cover.
Okay, well, I think that clarity is fine, but I suspect these minutes have already been approved by the committee, obviously, before they've come here, but I'm sure they can take that on board outside the meeting. Okay, we're not here to approve the minutes, we're just noting them here.
I just thought I'd get them correct, that was all.
Okay, thanks, Francis, for that. Mike, was there anything else, Mike Smith? You've got your hand up still, or is it a legacy hand?
I'm afraid that's my legacy to you all.
That's fine, thank you very much. Okay, if we can move on to item 14, which is the Commissioning Committee Assurance Report. And Pete, I've got you down as doing this in Peter's absence.
Yes, Chair, I'll try and do it justice, obviously different characters. So these are the assurance reports and the minutes from the previous meeting. So key things I'll pick out from the assurance report are, obviously you'll note that NHS are now progressing a go-live date of the 1st of August, and I think that's in recognition of the work that's still taking place in terms of the financial due diligence. That said, at the Commissioning Committee, we did see progress against the NHS action plan, and with the exception of the finances, good progress has been made in all other areas as we prepare for go live. We discussed it earlier in the board anyway, but we're seeing continued increased pressure on CAM services, but we did note in the committee some of the good work from our community teams about avoiding the need for an inpatient admission. And Adult Secure came to the meeting and gave an update on their plans for repatriation, and they've identified 41 patients with plans for repatriation over the next 41 months. And we also noted that the Adult Secure single point of access has gone live, and that's something the Trust is the provider of. We also got some good insight and breakdowns of activity for the financial year. And we did talk about finance, but I know we'll be picking up finance a little bit later on this morning. So if I stop there, Chair, I'm happy for any questions for either of my colleagues who are at the meeting to add anything.
Thanks, Pete. Any questions or anybody want to add anything? Now, can I just ask about the 41 people identified for repatriation? Is that back into Humber Coast and Vale, or is that both ways? Some from Humber Coast and Vale out and some in? How does it work?
Those 41, Sharon, are Humber Coast and Vale patients that we're planning to repatriate either into a Humber Coast and Vale bed or into a community setting. So we're doing work with other lead provider collaboratives at the moment about those patients that are in the Humber Centre or Clifton House who might be repatriated to a bed closer to them. So obviously that impacts on the overall financial modelling.
Okay, so that's not the net figure, that's the figure coming back into Humber Coast and Vale. Okay, thank you very much for that. Okay, if we could move on then please to item 15, which is the Board Assurance Framework. Oliver, welcome back to the board again. Good to see you again, and sorry to keep you waiting for a little while. So if we can move to the BAF, please. Michelle, I've got you down as having this on the agenda. Would you like to introduce this? Nearly.
Yeah, thanks, Chair. Nearly on mute. Thanks, Chair. No, I mean, obviously the work, just thanks to Oliver and the directors for support. Progress has been made. I think we have aligned it now a bit closer to the movement of current risk register, which I think was one of the comments that we made before. And we've altered the format a little bit to allow consideration to give to the risk and controls again, which was something that the board talked about. It is reviewed very regularly, both by the directors but also by the subcommittees, and I thank the subcommittees as well, because I know that goes on at that level and that scrutiny goes on there, which is really helpful, and there is real ownership of the board assurance framework. And what we're saying is that overall, everything's been maintained. There's been no immediate changes. I'll stop there and pass over to Oliver if there's anything Oliver wants to point out before we throw it open to questions. So thanks, Oliver, for your work.
Thanks, Michelle. I suppose the key points to that, as Michelle's indicated, the overall assurance ratings for each of the strategic goals have maintained from position from Q4 to Q1. I think there was definite discussion around potentially bringing some of those down. I think as we move into Q2, we will see some more sort of substantial changes to the overall ratings. I think obviously we were just coming into Q1, wanted to maintain as it was. In terms of some of these sections, obviously there are some new risks that have been added, and obviously each of the sections have been through the board subcommittee, that's the assuring committee for that particular strategic goal, as well as Michelle has mentioned. So obviously represents performance for position for Q1, and obviously then we'll continue the process as normal going into the new financial year as we go forward. I'm happy to take any questions at this stage. I think a few of you will have seen this document before, but any comments or any items that we need to look at going forward are welcomed as ever. Thank you.
Thanks, Oliver. Any questions on the BAF? Francis?
Just a minor comment, which we raised at finance on our risk, and also the same on strategic goal 4 on developing an effective and empowered workforce. It just seems interesting that on the workforce one, we've got 4 at red, 3 amber and 1 yellow, but overall we're yellow. So there's only 1 yellow one, but overall we're yellow. And similarly with strategic goal 5, we've got 1 red, 6 amber and only 1 yellow, but we're yellow overall. It just seems a slight anomaly that we've only got 1 yellow, yet we're yellow overall. Just something that we flagged at FIC.
Yes. I do think that's a fair point, Francis. Obviously, we'll take it away, consider it for Q2. I think the view that we take when we look at the document is we're seeking assurance against the strategic goal. Obviously, the risks are against individual elements of the objectives. So obviously we'll play a part of that. But I think particularly for the workforce, and I'm sure Steve will elaborate further, we've seen a lot of movement. We've got a hell of a lot of assurance now through the workforce and OD committee. So I think it was thought we approach it from an overall assurance rating to give a rating based on that. But I think the risks, obviously, they do play a part of it. We don't use that as the primary sort of indicator. But as I said, I'll review it and we can pick it up as part of the review process for Q2. And I'm happy to obviously hand over to Steve if there's anything Steve wants to add.
Steve?
Yeah, and I think it's a fair point. I guess what it doesn't show, Francis, is all the risks that we're managing really well and don't appear on there. So you can see there's something like 27 risks at, if you just look at the numbers. So there's a lot of risks. If we put everything on there, there'd be a lot more risks that were green and amber that may just balance some of that out. What we've got is the kind of higher ones on there. So the ones when we bring a more complete report, don't we, to Workforce Committee. So maybe that gives a better full picture of where we're at. But I totally take the point that the way it's presented visually, it looks like we're at the higher end, but obviously there's a number of others that are managed and well and we're very happy with.
And it's good, the explanation. It's just maybe we need to have that explanation, because if I was a member of the public looking at it, not knowing that background, I might question why we're yellow when everything isn't yellow. That's all.
No, I think it's a good challenge.
That's good point.
And it just shows that the challenge in the committees and the looking at it in more detail in the committee's works. Steve, sorry, was there anything you wanted to add? Did I cut you off there? Sorry.
Sorry, no, I just think it's a really good point, and I think we do need to address that, definitely.
Okay, thank you. Is there anything else on the BAF? I just had mine was more of an observation, actually, that for goals 1, 2 and 4, most of the actions are due obviously today. So I'm imagining we're going to see a bit of movement then, Oliver, in the next report that comes, because there are absolutely loads of actions that are going to be completed by today. And I realise some might have slipped, but going back to where you started, Oliver, that it implies that there should be quite a bit of movement in the next quarter's report.
Yes, definitely. I think obviously we are seeking those updates, and obviously, we've had conversations at Audit Committee in May as well about doing a sort of wrap up for the year-end position on how the actions have progressed in year, so up to Q4, which will be going to Audit Committee in August as well and via EMT ahead of that time. So we're making sure obviously those actions are being progressed, and particularly the ones that obviously that appear for the quarter end. Very conscious of the fact that we've given ourselves a timescale that we're at today. So we are addressing that, and we'll make sure that we've got those updates and they'll be incorporated into the next iteration as well. But I think that's a very valid point and something that we are very conscious of, and we will make sure is fully updated.
Thanks very much, Oliver. Thank you for that. Well, if we move on to item 16, which is the risk register update, Hilary.
Thanks, Sharon. So 7 risks on the trust-wide register. There's one new one on there, which is in relation to the CAMS capacity and the demand. That's that new risk that the Quality Committee had asked us to look at. So that's on there as well. And as you say, we've got the provider collaborative as well, risks on there, of which there's 4 of those. So I'll hand over to Oliver if he wants to say anything in particular about the risk register.
Thanks, Hilary. Yeah, I mean, obviously we've carried over from Q4 in terms of the existing workforce and financial entries, which you'll all be familiar with. Obviously, it was felt that they're still pertinent, still at the relevant score to be included on the trust-wide risk register coming into Q1. As ever, obviously, they'll go through monthly reviews ahead of the report going through the board subcommittees and board next time around for Q2. Obviously, we have had the new risk ops 13, which is the risk around the CAMS inpatient bed situation nationally. That is a fairly new risk, so there will be some development on that one and further information to be included. So that is just an initial entry at that particular risk. And obviously Hilary's mentioned around the 4, 15 or above risks in regards to the provider collaborative as well. So you may recall for Q1 we did try a different iteration of the board assurance framework where we had a commissioning section, and it was thought that was probably not the best way to manage it going forward. So the view is now that we will keep the BAF distinct as a provider BAF for us as an organisation, and we will cite the 15 above commissioning risks as part of this report alongside the trust-wide risk register going forward. In terms of just oversight, in terms of just the general numbers of risk, you'll notice within the report there is a breakdown on the total number of risks going from last reported in March to where we currently sit in June. We did see a slight reduction of 21 risks going from 203 to 182, but obviously that's just evident of the movement of the risks coming into the new financial year, and obviously we are starting to see new risks be added as well, particularly in the divisions and across the directorate. So we will see a bit of a jump, I would have thought, going into Q2 from Q1. We tend to see that drop from Q4 into Q1, and that's normally the position. So no concerns there, and obviously we've closing down the original COVID-19 Silver Command risk register, and those risks have been apportioned out where required at divisional and directorate level as well. So we've made sure anything that did carry over has been appropriately managed and is being sort of monitored and reviewed regularly through those other risk register arrangements as well. So happy to take any comments, questions as usual. I think that's all probably saying everything in terms of summary for that report today.
Thanks very much, Oliver. And Mike Cook.
Thanks, Sharon. A couple of comments really and an observation. It's good that this is dynamic, and I do feel in closing down the COVID command risk register that was really well handled, and the read across between that, the clarity of that, and the ongoing risk register was good. So I make a plea for the same to happen with the commissioning, the provider collaborative, because we've got 7 risks which we know quite a bit about, and now 4 pretty new ones. So I, for one, was pleased to see that the date had gone back a little bit on implementation. But, you know, when you've got 2 risks coming in at 25 and they're new risks, we just need to note that, you know, of 11 risks, 4 are new. And I think we just need to observe that as a board, in that there's a risk reservoir. There's only so much risk any organisation can take on at any one time. And, you know, we're very positive about it, but it is quite a big risk. And that's what the execs are saying to us through this. So it's really an observation. And I think the work to do between the risk registers is as important as the actual presentation of the actual risk register. Thank you.
Thanks, Mike. Dean?
Yeah, thanks again, Oliver, for the comprehensive update. It's good to see. I know we raised last time round about the provider collaborative risks and just changing the wording, because I think last time round it sort of implied going ahead. I know we've still got to make a decision yet once we consider those risks. So I think that the wording now better reflects where we are in respect of that. I just wondered though whether sort of CC1 and CC9 are the same risk.
Yeah, I mean, they're very similar, aren't they, in terms of the wording. Unfortunately, I'm not overly close to this risk register. Obviously, being the provider's risk manager, I'm sort of more involved with ours and just bringing it in for the reporting element. So I'll pick it up with colleagues that sit within the provider collaborative that are obviously managing this risk register. I don't know if you have any views on that, Pete.
I think Pete's going to contribute. Pete?
Thanks, Sharon. I think what we're trying to do there, Dean, is separate. So CC1 is the risk that the initial budget transfer isn't correct, and that's the thing we've been flagging from due diligence. CC9 is more about if for whatever reason our demand modelling and planning sees increase in demand for the beds that we're now commissioning. So 1 is about point of transfer, 9 is about medium term planning, and actually if we start to see growth in that activity, which is different to the envelope on what we'd planned as part of our business case. So it could probably be worded a little bit differently, but I think that's the separation between the two.
And I think CC13 is probably more that sort of future risk issues, isn't it? But yeah, I know it's a tricky one to sort of express given where we are in terms of the decision making process, but just flagging it up. Thank you.
No, thanks, Dane. Thanks, Pete. Anything else from anybody? I've just got a couple. Oliver, just on the actual risk register itself, and it's probably just a timing issue, but quite a lot of the gaps in assurance and some of the additional actions relate back to figures in March, for example, and actions for March. Is there any reason for that? Is it because it's benchmark at the end of the last quarter? What's the point?
Yeah, I think you're referring to the workforce risks, aren't you, Sharon, particularly? We do it based on the insight report, so it's when it's made available and it just goes through our process of review. So I think we are a couple of months behind in terms of that. We are due to update it, I believe, this week in terms of the next data set. So I think it's purely a timing sort of situation. I can have a look to see if we can tighten that up ahead of the next report, if that's possible, but obviously it's dependent fully on that data becoming available. So I can definitely explore it, and obviously then if there's any more up-to-date data, then I think if anything it'd probably be a month ahead as opposed to necessarily be for May's data, let's say. So but I can explore that definitely, and we can see if we can include any more up-to-date information ahead of the next report.
No, thanks. It's just that, for example, consultant vacancies, well, the board's ratified a number of appointments since then, but this goes back to March data. And then we, in one of the actions, the first one, we talked to additional actions need to be completed, the budget reduction strategy implementation with a March date. It's those kind of things. There's quite a few dates in this one that are linked back to March, and we're now at the end of June. So I was just asking if it was possible to have a more updated information. So if you could look at that, that would be good.
We'll explore it, definitely. Thanks, Sharon.
Thanks, Oliver. Anything else for Oliver? No, thank you ever so much, as usual, Oliver. Loads of work going on in the background, so thank you very much for that, and we'll no doubt see you soon.
Thanks, everybody.
Thanks. So if we can move on to item 17, the annual non-clinical safety report. Pete.
Thank you, Chair. So this is the annual non-clinical safety report. From a governance point of view, this was reviewed and approved for submission by the Trust's Health and Safety Group, and then came via ENT, and obviously Francis, via his FIC assurance report, recommended it for approval to the board. There's a lot of detail in the body of the report, so if I pull out just some of the main headlines. So for the last financial year, we had 3 RIDOR incidents, which compares to 5 from the previous year. We had no enforcement notices received. All our health and safety policies were up to date. 4 fire incidents during the year. Continued good training compliance, which is good to see. And then we include at the back of the report, the details of the inspections we undertook during the year as an appendix. And we've also included for the first time this year, the compliance dashboards, which we take to the health and safety group and then up to EMT on a regular basis. And where relevant, we've referenced, how COVID has impacted how we maybe did our inspections and how we changed our approach during the year. So I'll stop there, Chair. It's here today for approval, I think, or to receive a note. Sorry, I'm forgetting it.
No, thank you, Pete. Mike Smith.
What could be seen as a minor point, but I don't think it is, and it's the cover photograph, Pete. It's about the appropriateness and relevance of it. Appropriateness in terms of that safety report covers the period that was wholly within COVID regulations, what you've got as a group photo. And the other one is about the relevance of it, that you've got a whole army of people who are looking after us in a non-clinical way. And that photograph doesn't do justice to that. And I just wondered whether there could be a montage of the things that are done in fire safety and water and some of the staff. Because we do want to say that it's not just a boring report, it actually reflects the way that our premises and our people are kept safe. Is that okay?
Yeah, that's a good comment, Mike. I'll have a chat with Michelle Hughes and comms about, you know, whether or not we can get some of the estates and the safety team photographed.
Okay, thank you for that, Mike. Mike Cook.
I think I lost the point about the title of the report a couple of years ago, Annual Non-Clinical Safety. I can see why you're calling it that, but actually there's a lot about quality and clinical safety around this for patients, staff and visitors. You know, so I don't know whether it is relevant for you to bring it to quality as well, but I don't exclude parts of the organisation. You know, patients are our core business, and you know, quality committee needs to just be assured that we're doing all we can on this sort of important topic. We've had a very interesting conversation about ligature points, but actually the therapeutic environment that we create being probably more important than those points. So it's some things like that that might just be useful to consider. But I understand, you know, why it comes as it comes, but I think I've made the point before.
Okay, thanks, Mike. So Pete, could you, just as an action, just take away to look at the photograph on the front, what you can do with that as possibility, and also consider for next year's cycle of business whether it would be appropriate for it to go to quality committee as well as FIC.
Yeah, more than happy to do so. And you know, I know we talked about the title a couple of times in the past, and I don't want to say suggestions on a postcard, Chair, but you know, I'm not going to die in the ditch on the title.
Okay, thank you very much. If you could look at that as well, then Pete, that'd be great. Dean.
Yeah, it's just an opportunity to build upon Mike Smith's point, and an opportunity to say thank you, isn't it, to those staff. So these are areas that, you know, don't necessarily get a lot of sort of look in terms of fire safety and trips and falls and water safety and security. And when they're going well, we don't necessarily think about them, but when they go wrong, they can go drastically wrong. And I think it's testament to all those people working diligently, often unappreciated, I think, sometimes seen as, you know, back office, when they're doing an essential job, as Mike says, keeping us all safe. So thanks to everyone involved in it.
Thanks, Dean. I'll pass that on to the team.
Mike Smith, did you want to say something?
Yeah, you might consider, Pete, doing a forward to it like Michelle does for hers that says so at the beginning of the report.
Yeah, happy to consider that, Mike.
Okay, well, you're adding to your list for consideration for next year, Pete. I think we're up to 4 actions being able to just look at for next year, so that'll be good. John?
Will help me write it.
I just want to compliment the team on some brilliant work they did around the COVID response, and particularly around the vaccine centre. You know, Pete Dent and the guys, Paul Dent, the guys are onto it. Actually went from security purposes, we need to change doors to protect the vaccines that we have in storage. All of these things just happened seamlessly through Paul and the team working with the state. So when it comes to getting stuff done on the ground, we have that response in place, or I certainly saw that this year. So thanks, Pete.
No, thanks you for all your comments. And can I say, I mean, you can see it from this report, but also from the FIC assurance report, how busy some of the support services that you've all mentioned have been. I mean, if you look at the finance assurance report, you can see, for example, the estates team, how incredibly busy they've been elsewhere. And so, you know, in terms of it does need acknowledging. And I think that's one of the reasons, and I know Michelle and I have talked about this before, and as a board we have, that's one of the reasons why all of the staff thank yous are to all staff. Because everybody's playing their part, aren't they? And everybody's contributing. And so I know from feedback from the staff governors how much it has been appreciated. I know Michelle's had some of this direct, haven't you, Michelle, from the staff governors, that they felt that it's very inclusive and it's sent a really strong message that all staff are contributing. And so all staff are acknowledged as contributing. So it's a really good point. But yeah, loads of great work gone in here and behind the scenes. So thank you to everybody concerned for that, because it does play a really vital role. So thank you for that. We've duly noted it, Pete, and you've taken away your 4 actions to review for next year, so that's fine. If we could please move on then to item 18, the Humber Coast and Vale strategic objectives, Michelle.
Yeah, thanks, Chair. I'm sure people have had a chance to read the strategic objectives. These have been actually ongoing quite a while and have been around various different groups. They're in the main the transition piece, so they're really sort of linked into obviously the COVID response, how the ICS is developing its operational plan, how it starts to establish itself, developing actually the infrastructure of the ICS on the back of the white paper that's just about to get into the House of Commons, and the transition from where we are now to where we need to be, subject obviously to ratification in the House. So it's just there for information. There is no firm trajectories underneath this yet. I think the next piece of work is to develop the trajectories and to develop the plans underneath each one, but it really gives that picture around continuing with the pandemic, but then linking into the transition process as we develop into the ICS and that operating plan. But I'll stop there, Chair, because it's fairly self-explanatory.
Thanks, Michelle. And I know we're hoping that I know you've actioned that Stephen hopefully will join us at our next board development time out as well. So that's good. We're working with Stephen on his availability at the moment. Anything on that from anybody? No, thank you very much. We can move on then to item 19, which is the integrated care system design principles, Michelle.
Yeah, the long-awaited design principles for the ICS were actually released during the month, and I'm sure others around the table will have experience of the commentary and the discussions on those. We're still waiting for quite a bit of technical guidance, particularly around provider collaborative, though we are pressing on in relationship to where we're at in the Humber Coast and Vale. So we just tried to pick out bits in relationship to the system design. So I think it's very much as we've said, really, which is mainly around bringing organisations together, system first, functions versus form, and around the core purpose being inequalities. There's a strong push around tackling inequalities, but also around outcome focus. And I think we've been talking about being outcome focused for a while. So there is a real push in relationship to not just inequalities, but tackling outcomes and the social and economic development, and how NHS organisations can play a real part as both place and as a system. So it goes on to about the partnerships, and it goes on about the ICS partnership and then the NHS partnership, because obviously what we want to do is keep that core of the NHS and the partnerships, but also develop that wider system, because I think we've all appreciated that it's about systems contribution to care and to health and well-being rather than just particular individual organisations. So the focus of the ICS body is obviously to develop a plan. We've just seen that in the objectives that we've just seen. Establishing working relationships, the transition from A to B, the provision of health and healthcare across the patch, around the sustainability, we've mentioned anchor organisations, and then obviously the transfer subject to parliamentary approval, the commissioning functions from the CCGs into the ICS, and then obviously we're waiting for more technical guidance about how that next reiteration. But also importantly, there are people involved here as well, so developing that people's plan and an efficient workforce across the ICS, and supporting those people is vitally important. It does, if the white paper and the design principles do affect providers. I think this is a bit of a misnomer that it's just about commissioning and an ICS developments in place, that there is strong links into partnerships, as we've mentioned, and provider collaboratives, and each provider organisation in the NHS has to become a partner or a part of a provider collaborative. And obviously we're in a couple. We're in the learning disability, mental health and autism one. We're also a key contributor in the community collaborative, and we've just set up a primary care collaborative that we're equally involved with, and we will have some links into the acute one, because obviously mental health, particularly in acute, can't be separated out. So I'll leave it there. There's more to follow. It's just a bit of a starter for 10 really. We'll link into our strategic day, and we'll await the technical guidance when it comes out. But I'll pause there, Chair. Thank you.
Thanks very much, Michelle. John? You're on mute, John.
Yeah, third time lucky, isn't it? Michelle, you quite rightly mentioned health inequalities at the start of your piece on the ICS. Now, I, for one, have been pretty vocal that if we're going to take health inequalities seriously at a system, not just does it need to have an executive lead at the ICS level, actually it needs to have an executive lead who, dare I say it, has the academic background or is from a public health background to help us drive that agenda, because I fear like some things, these things become a fad, and actually we need that health inequalities, public health background right at the centre of the executive function of a new ICS structure, and perhaps not just sitting more remotely, from a board perspective. I just need to get that off my chest, because I feel the health inequalities and social inequalities are a big challenge we're going to face over the next 5 years. We have a chance of a new structure, and we either get it right or we don't at the start. That's my perspective as the health inequalities lead in Humber.
Well, that's fine, John. You don't need to apologise for, sort of championing the cause. Thank you. Oh, Dean, did you have your hand raised?
Yeah, it was a similar point to John's really about health inequalities, and I know we said here before, haven't we, that the health service can't sort all this out. It's transport, it's education, it's housing, that all has an impact upon those. But in terms of social and economic development, where we can make a difference, I think, is as an employer. Providing good, stable employment for people in enjoyable work where they can sort of make a contribution and, take healthcare messages back home. And I agree with John in terms of the stuff at the centre, but where we can make a difference, I think is in that sort of employment space. Work we do with apprenticeships, encouraging people from schools to get jobs in health and social care that can be stable and valuable to people, I think is a real good opportunity for us. Thank you.
Thanks, Dean. Okay, thank you very much, everybody, and thank you for bringing those, Michelle. So item 20, items for escalation. I'm not aware of any, unless anybody's got any. Any other business? Again, not aware of any. Has anybody got any other business? No, well, with that, we will close the part one, the meeting in public. So thank you very much to anybody who's joined us virtually. Really good that you've done so. And thank you, board members. Adam, if you could just confirm when the live streaming stopped, please.